Okay, well, welcome, Mohammed, for our fourth and last session on the topic of alcohol.
Yes.
So, I think that out of the different topics to choose from, I felt alcohol was a good one to touch on. Whenever you do inpatient rounds, alcohol oftentimes is a huge part of the service, actually, when you have your census of patients, to the extent where sometimes there's actually an alcohol detox service by itself.
Yep.
So alcohol plays a large role in inpatient life. And in the outpatient world, I think that it sometimes can be hidden a little bit, and you have to kind of be attuned to history and certain cues in the history and the exam. So today we'll talk a lot about that aspect of things, and then towards the end, a little bit about treatment.
Okay.
So an important area within primary care, not just addiction medicine, but something that family physicians also have a significant role in.
Counseling.
What's that now?
Counseling
Well,
the
there's
patients
counseling. Yep.
to.
Yeah, there's counseling that the primary care provider definitely has an important role there, and also medication assisted treatment. So the use of pharmacotherapy in the treatment of alcohol use disorder. So we'll talk a little bit about that. So yes, so this is our topic for the day. Otherwise, Mohammed, how was your week? Did you have a good week?
Yeah, it was good.
Good.
Um, yeah, I did my OET exam.
Oh, is
I
that
told you
right?
last week I was studying for it.
What's that now?
I told you I was studying for it last week when you asked me. So I
That's
just
right.
did it. Yeah, yesterday. Finally, I'm done now. I can focus more on my application, filling it up, getting all required documents.
Okay, wonderful, wonderful. Was the exam hard?
It wasn't. No, I wouldn't say so.
Good, good, wonderful. All right, good to
Thankfully,
hear.
yeah.
Yeah, awesome, awesome. Okay, well, congratulations. That's good. When do you get your score back?
In 2 weeks. It takes some time.
Oh yeah, yeah, very interesting.
Yeah,
Okay. Oh, 2 weeks
but I
isn't
have
bad
time
though.
until the application, which is end of September. So I have enough time, I think.
Wonderful, wonderful. Good, good. Okay. Well, best of luck.
Thank you.
Yeah, yeah, it's exciting. All right, Mohammed, let's jump right into it. So, this first case, a 45-year-old man with an enlarged liver. So, let's say you have a 45-year-old executive that comes to your office, and he comes in for a periodic health assessment. He tells you that he's been feeling weak, tired, and just not himself lately. He also tells you that he has been so tired that he has had to stay home from work for many days at a time. He is beginning to question his ability to function effectively as a chief executive officer of a transportation company. When you inquire about other symptoms, he tells you that he has suffered from profound headaches and that his sex life with his wife is quote unquote in the pits. On direct questioning, he tells you that the headaches have been a problem for the past 6 months, and his lack of interest in sex has been a problem for approximately the same amount of time. He has no serious past medical, surgical, or psychiatric illnesses. He tells you that he is taking no over-the-counter or prescription drugs. The patient describes himself as a social drinker, and his use of alcohol is strictly to relax. He then states, "I hope you do not think I'm an alcoholic, doc. There is no evidence of acute intoxication at this time." He does state on more persistent questioning, "Well, maybe I am using more alcohol than I did a few years ago. Sometimes I think it might be a good idea to cut down a bit. I do get annoyed with my wife, who points out that I'm drinking more than I used to. Sometimes I even feel guilty and wonder if that's affecting our sex life. There are mornings that I wake up with the shakes, and having an eye opener, which having an eye opener really helps. Now, his father died of complications of quote unquote yellow jaundice at age 61 years. His mother died of complications of heart failure at age 69. He has three brothers and 2 sisters, and all are well. On physical exam, his blood pressure is 160/104. His pulse is 96 and regular. Examination findings of the head and neck, respiratory system, and musculoskeletal system are normal. Examination of the cardiovascular system reveals a point of maximal impulse in the 5th intercostal space of the anterior axillary line. He subsequently describes episodes of waking up at night short of breath and shortness of breath on exertion. Examination of the gastrointestinal system reveals no tenderness or rebound tenderness. The liver edge is palpated approximately 5 centimeters below the costal margin. Examination of the neurological system reveals intermittent carpal spasms of both extremities. He has a fine tremor of his hands. He cannot perform serial 7s and has difficulty with the recall of information on the mental status exam. So, Mohammed, before jumping to the questions, so what do you make of his cardiovascular exam?
Cardiovascular, he seems to have alcohol abuse, and alcohol can cause cardiomyopathy, which might be presenting as this heart failure. He's having an enlargement of the heart. And yeah, he has some liver symptoms as well related to his alcohol use.
Yeah.
His estrogen, testosterone imbalance causing him problems in his sex life.
Right.
And as well. Yeah, so it does make sense that his alcohol abuse is causing his symptoms.
Yeah. What do you make of the carpal spasms?
Neuropathy, it might be caused by this
Right.
by his alcohol abuse.
Yeah, definitely peripheral neuropathy is a prominent feature of chronic alcohol use disorder. And I don't know, we'll check the answers together, but for me, I was thinking that this is this might be related to hypocalcemia, because electrolyte aberrations are also a feature of alcohol use disorder. Patients will oftentimes have hyponatremia, hypokalemia, as well as other electrolyte aberrations. So that's what it was reminiscent of for me. And then of course the fine tremor of the hands, that certainly, can be a feature of alcoholic liver disease. So yeah, and of course the cognitive issues as well. Okay. And then going back to cardiovascular, we have significant hypertension. So we know that alcohol is a prominent cause of secondary hypertension. I believe most common cause of secondary hypertension in males is alcohol, whereas in females, most common cause of secondary hypertension is oral contraceptive pills. So, okay, I think let's see what the questions are. So with the history given, what is the best description of the most likely diagnosis in this patient? What do you say?
Most likely would be D, although more investigation needed to be done on his depressive symptoms.
Right.
He's not going to work. He's also his sex life, his headache can be a primary presentation at the beginning. So, but I will go with D.
Yeah, definitely. I would agree. Adjustment disorder, there was no major event that happened. Somatization disorder, there was, his exam doesn't really suggest that. Major depressive disorder, absolutely, I agree. That's something that can, needs to be ruled out, can be something comorbid.
Yeah,
But
yeah, comorbid, yeah.
but I think but the way the history is taken, it even includes a cage questionnaire actually here, where he's tried to cut down, he's annoyed, he
The
feels
cage, I
guilty.
was reading about it
Yeah.
when I knew the subject of this week.
Mhm.
And on the AFP website, they mentioned it and they said that it's not recommended anymore
Mhm.
because of the accuracy. But
Right.
they mentioned somewhere about some more accurate questions, like his increase in the use of alcohol.
Right.
It's getting hard for him to stop. These
Right.
are more accurate, maybe.
Yeah, let's there is another questionnaire called if I'm not mistaken, there is the audit questionnaire. Let me see if I can pull it up here. So let me see if that's something that the AAFP recommends. So AAFP alcohol screening. Let's see if we can bring it up.
Maybe I'll share.
Let's see. Let me share this screen and let's see what we can find. But you bring up a good point. You bring up a good point that, these tools, as they're, we have better information on how valid they are over time. Let me see if I can properly. Oh, somebody's chatting. Oh, that's you. Oh, that's it. Oh, wow. Thank you. Thank you, Mohammed. Appreciate it. Perfect. All right. Let's take a look here. There's medications for alcohol use, certainly. There's
Yeah.
that.
If you go to table 1, below the medication, you can see the criteria, the newest up-to-date criteria for the diagnosis.
Okay, sure. Let me share the screen here. This is, want to share the Safari. There it
How
is.
about your week? Sorry, I didn't ask. It was vacation in the US.
My week, well, let's see. Yeah, it was July 4th,
Yeah.
and basically, it was July 4th, and we had Monday off. So
Mm-hmm.
not the whole week. Oh, we wish. That would be amazing. So yeah, we had Monday off. It was good.
Oh,
Yeah,
okay.
yeah, it was good catch-up time, to be honest. So yeah, no, thank you. It was a very good week. So yes, I see here that if we're looking at the guidelines, so thank you so much for pulling it up. So the USPSTF recommends screening adults for alcohol misuse and providing persons engaged in risky or hazardous behaviors with brief counseling to avoid misuse. Okay, now as far as screening, it looks like indeed we have the audit and the audit C questionnaire. So perfect.
Yeah.
All right, good. So
And
basically,
here, besides, yeah, although the CAGE questionnaire is familiar to clinicians, its accuracy varies in ambulatory settings, so it's not
right,
recommended by USPS.
by the USPSTF. Perfect. Yeah, thank you. Excellent. So individuals who engage in high-risk drinking should be counseled, and patients diagnosed with alcohol use disorder should be offered treatment, such as brief behavioral interventions, support programs, individual group therapy, and medications. Okay, if we just kind of read along here. So this is the validated screening method for alcohol use disorder recommended by the United States Preventive Service Task Force. When we have three, we have the audit 10, the audit C, and then the single question screening. So I can tell you, Mohammed, that at my organization, we actually use the single question screening. That's what we do. And we do that routinely actually for every patient. So that's what we have done in an ambulatory setting to address this issue. So yeah, how many times in the past year have you had 5 or 4 drinks in one day? A lot of times we'll ask in one sitting. And then if this comes up positive, then a lot of times we will then a lot of times we will then jump to one of these other questionnaires. I believe at our organization we go to the audit C actually next. But yeah, so yeah, thank you for bringing that up for our discussion. And for the single question screening, you just need at least 1 day. So just 1 day in the past year that you've had this episode. So okay, good, excellent. So now we're up to date on that. Let's see, new share, and where are we? Boy, sometimes it's so hard to share the right screen. Let me see here. Desktop, no, not desktop, there it is, okay. Excellent. Okay, perfect. All right, so, okay, so number one, I think we were settled on that. And, you know, I think if we, now this actually brings up the question of, you know, what's the diagnostic criteria of alcohol use disorder? So I can, allow me to run through that real quick. So this patient has alcohol use disorder. So that is the answer. I think no surprise there. So it's defined as at least 2 of the following within during a 12-month period. Either so it's a bunch of criteria. I think just quickly, tolerance, characteristic withdrawal symptoms. The substance is taken in larger amounts for a longer period of time than the person intended.
Yes.
The desire or 1 or more unsuccessful attempts to cut down. Great deal of time spent in getting alcohol. Yeah. Continued alcohol use despite knowing that it has harms from a social, psychological, physical aspect. And recurrent use resulting in failure to fulfill major obligations at work. And that's really, you know, it'll affect your personal life before work, actually. Once when it starts to affect work, that's a distinct,
yes.
But although this point is that it results in failure of obligations at work, home, or school. But in general, you know, just from experience, work tends to come later. It'll impact home first. But yes, when you're failing to fulfill major obligations because of this issue, and then also recurrent use in situations where it is physically hazardous. And lastly, craving or a strong desire to use alcohol. So according to DSM-5, if you have at least 2 of those criteria met within a 12-month period, then you fulfill the diagnosis of alcohol use disorder. Yeah. And the severity is defined as mild, where you have 2 to 3 of these criteria, moderate, which is 4 to 5 of these criteria, and then severe, which is 6 or more criteria. So that's pretty much the diagnostic criteria. Okay, so moving on. Which of the following signs or symptoms further substantiate your diagnosis in this patient? What would you say?
All of the above.
You know, I would agree as well.
We already went through them one by one, and
yeah,
they are also.
Yep. Absolutely, yeah. So we pretty much hit that. Let's see if our text has any other points here. We talked about the cardiomyopathy. We talked about the obvious hepatosplenomegaly, which suggests either the hepatosplenomegaly can suggest either alcoholic hepatitis or cirrhosis. The fine tremor suggests early alcoholic encephalopathy, which is substantiated by the cognitive dysfunction.
Mental status, yeah.
Exactly. And then the patient's hypertension suggests alcohol as a potential cause. So, okay, perfect. All right, so we're good there. All right, next up. What are the signs and symptoms of acute alcohol intoxication? What would you say?
All of the above.
Yeah, and I would agree. I would pick all of the above as well. I'm pretty sure that's right, but let's see. So alcohol intoxication is characterized by mood lability. So sometimes patients, you know, they might cry easily, for example, or they might get angry easily. Poor judgment, ataxia, slurred speech, decreased concentration and memory. And that's very important, by the way, in the outpatient setting, because patients will come in with that chief complaint, poor memory or poor attention, and they may want ADHD meds because of it, actually. So there's actually one patient I can recall. She came in with a diagnosis of ADHD. And what happened was she was on stimulants. She came in on this. And actually, when we evaluated things further, eventually we got a urine drug screen, and it showed significant alcohol. It showed alcohol in her system, and it was in the morning. It was like, she came in for a morning appointment, and so the presence of alcohol in your system after coming in, for a 9-10 a.m. appointment, that kind of suspicious. And then when you press her further as far as history, it's not it's vague. And so it's interesting because she has this history. She has so really alcohol use disorder could be really the cause of her attention issues. And instead of being on a stimulant, she shouldn't then be on a stimulant, because this will exacerbate the hypertension she already has. So I think that's why it's important to think of this in the primary care setting. We talked about facial flushing, blood pressure elevation, enlarged pupils in acute alcohol intoxication. Nystagmus.
Why would facial flushing happen?
What's that?
Facial flushing, why would that happen?
Yeah, so basically, so if I remember right, you would ask that, because I was thinking of double checking that before this morning. So there is, when alcohol is broken down, there is there's a metabolite which I forget. It's like it's a type of aldehyde. And I wonder if I can see what it is real quick. This actually comes into play with the disulfiram. And actually, yeah. So this comes into play because the disulfiram precipitates that kind of reaction.
Yeah.
So basically, it's acetaldehyde. That's right. So acetaldehyde is a metabolite. And when you have a lot of alcohol, then you have, you have the metabolic process that happens. Acetaldehyde builds up, and acetaldehyde can cause the facial flushing, actually. And that's why when you take disulfiram inhibits, oh gosh, this is embarrassing. I forgot the name of the enzyme. I want to say it was a dehydrogenase. There was a dehydrogenase enzyme that disulfiram inhibits. And then you have this buildup of acetaldehyde, and you have this bad reaction. So the other thing is that alcohol, I'm thinking it may serve as a vasodilator as well. So anyway, I believe that's why. But maybe before we log off today, we can double check that.
Okay.
Yeah. Okay. Good. I think that's pretty much it. Of course, if it's severely acute, you can have respiratory depression, and then you can have decrease in blood pressure, body temperature, stupor, coma, death. So, All right, good. Now, Mohammed, I'm gonna allow me to break away for 3 minutes. Let me address something in the office here. I'll be right back.
Okay, sure.
But here's the next question. Let's think about that one. All right. Okay, Mohammed, what'd you find out?
I think it's the alcoholic hepatitis or cirrhosis. Also, we discussed that. And, although it can be caused by the heart failure,
What's that?
but
Although it can be caused this. Okay, maybe I'll read it first because you weren't here. So they are asking, what's the most likely cause of this patient's liver edge palpated at 5 centimeters below the right costal margin?
Mm-hmm.
It's most probably B.
Yeah. And I think we had talked about that. Absolutely.
Mm-hmm.
By the way, I just double checked. I sat down here and just double checked. So disulfiram, it inhibits the aldehyde dehydrogenase.
Yeah.
So there we go. So it's the aldehyde dehydrogenase, and then that it's the aldehyde dehydrogenase that breaks down the acetaldehyde. And so this is the presence of aldehyde dehydrogenase. It's genetic actually. And so there are variations between different groups of people, also
races.
Exactly, yeah. So sometimes some ethnicities, so for example, maybe perhaps Southeast Asian communities, they may not have a lot of aldehyde dehydrogenase. So just a little bit of alcohol is enough to give a reaction, for example.
Yeah.
So there's some genetic reasons for that. And then disulfiram, one of the treatments for alcohol use disorder, which is not first line necessarily, but it inhibits that enzyme. So can I give you?
It's used after abstaining from alcohol, not during, because during they will not use it. Most probably the patients.
Yeah, it's like an avoidance treatment, and we'll come to that with our very last question, I think. But
Okay.
yes, if they drink alcohol while they're taking this med, then they will develop a reaction. By the way, a trivia question is, what antibiotic can trigger a disulfiram-like reaction?
Metronidazole.
Excellent, Mohammed. My goodness, you should have no problem with your board exams, I think. So, all right. So B is definitely the answer for number 4. The most likely cause of the hepatomegaly is the alcoholic hepatitis, possibly cirrhosis. elevated enzymes such as gamma glutamyl transferase, so GGT, AST, ALT can occur. By the way, what ratio of AST to ALT do you usually get in the setting of alcohol?
2 to 1.
Mhm.
Usually we look if AST is double the amount of ALT, we start thinking there must be an alcohol related problem.
Yeah, yeah, absolutely. Things like fatty liver disease, a lot of medication reactions that will affect the liver. You know, it's either about the same or more ALT. But when you have
Yes.
more AST than ALT, then yeah, you definitely start thinking about that. Other laboratory issues is the mean corpuscular volume tends to be elevated, and I think we understand that there's going to be a lack of folate, and that can affect that. Uric acid levels tend to be elevated. Lipid metabolism is abnormal. And then just in general, a lot of times when you see patients, it's really interesting actually, when you see patients in the hospital, like it's almost like everything is low. Electrolytes are low. If there's poor nutrition, a lot of times BUN is low. Unless there's like an upper GI bleed, then the BUN is high. Then their white count will be suppressed. They're anemic. Their platelets are low because of alcohol. Like, you just look at it, and you know how in the hospital, like, you get a CBC BMP, a lot of times we'll just get that routinely every morning.
Yes.
Which, you would argue you shouldn't do it for no reason, but it's interesting. You round on patients and they're just all low. That's sort of like a hallmark almost. So, okay, sounds good. Well, let's move on to number 5. There is a high correlation between the disorder diagnosed in question 1, alcohol use disorder, and which of the following syndromes? So when talking about comorbid conditions. What would you say?
Major depressive for sure, general anxiety 2, opioids or abuse of other drugs. So I'm leaning toward E.
All of the above. So I don't know the answer for
Schizophrenia?
sure. Was that? Yeah. That's the part that makes me suspicious. Like schizophrenia, I don't know. I'm not really sure if there's an association there. So. Still sticking with E?
Yeah, let's see. Yeah.
Okay. So if it were me, I think major depressive, I think for sure. Opioid use, I think can go hand in hand. Well, not go hand in hand. There's
Correlation.
Yeah. So I think just from experience, I might say D, but A, frankly, is very attractive. So that's why all of the above. But the schizophrenia part, it just makes me suspicious. So I feel like maybe the best answer is F.
Okay.
So let's take a look.
Makes sense too.
But no, Mohammed, you are correct. You're correct. Yeah. Okay, Mohammed, next time if we do this again, we'll have you lead it, okay? You are correct, sir. It is E. It is E. You are correct. So let's take a look at this. So the National Institute of Mental Health Epidemiologic Catchment Area Program found a very high correlation rate between alcoholism and suicide, homicide, accidents, anxiety disorders, major depressive disorder, schizophrenia, narcotic drug abuse, cocaine abuse, and cigarette smoking. So, that's the list of correlations. So I stand corrected. Schizophrenia looks like there is an association.
Yeah, because the word correlation, it's not causation, it's not causing schizophrenia, but probably people with schizophrenia, if they can turn into alcohol as well.
Yeah, good call, Mohammed. Thank you. Good job. So Good. Yes, wonderful. All right, moving on. Number 6, the patient's inability to perform serial 7s and information recall is most likely caused by which of the following? What would you say? In this patient, this patient who is how old? How old was he, did we say? 45-year-old.
Dementia? No.
Yeah.
Maybe C, although I'm not sure. Let me check.
Yeah.
B.
B. Yeah. I guess, yeah, I like B too. I like B. C, alcoholic amnestic syndrome. Yeah. Yeah. I think Alzheimer's dementia, I just think is less likely because he's a 45-year-old. So I'll be honest, I have not ever documented alcoholic amnestic syndrome in the office.
Oh, I just Googled it and they mentioned Korsakoff's, just another name for
Really?
Korsakoff syndrome.
Okay. So maybe it's, yeah, I feel like I'm trying to actually distinguish this B and C. So maybe we should just pick B and C. Well, let's see what the answer is, shall we?
Sure.
Number 6, the answer is E in this case, B and C. Wonderful. Good. Okay. So what's the deal here? So chronic alcohol use is associated with the cognitive and memory deficits of alcoholic dementia and the more restrictive memory deficits of alcohol amnestic disorder. Patients with alcohol-related amnestic syndrome have the most difficulty with short-term memory, in other words, remembering recent events. However, deficits may be noted in long-term memory as well. Okay. So based on this, I'm wondering, do we have a clear understanding on what's the difference between the two? I think the difference may be that in dementia, it's other cognitive difficulties rather than just memory. Yeah. So, because here, performing serial 7s, to me, that's more, if we recall that part of the mini mental status exam, to me, that's more cognitive rather than memory. So I think that's probably the difference between the two. Whereas the dementia, it's general cognitive problems, including short-term memory problems, and alcoholic amnestic syndrome, it's more restricted to memory issues, primarily short-term memory. So
yeah,
okay, sounds good.
makes sense.
See, so one item about test taking too is that sometimes you don't have to fully know the answer to get the question right.
Yeah.
Just remember that. I think, just because you don't know the answer doesn't mean you can get it right. Sometimes when taking a test, I feel like, okay, I don't know the answer, but I know something about this question. I know something here and there. So based on what I know, can that lead me to the right answer? Maybe I don't know the answer, but I can be led to the right answer, if that makes sense. So that's a mentality for test taking that I feel is helpful. So,
extremely helpful, yeah. Canceling other choices.
Yeah. Exactly. So you can have confidence during the test. It's like, it's true, I don't know the answer, but what do I know about this? Based on what I know, what answer will what I know lead me to? You know, logically, which one would I go to based on what I know? So you think about that. So it's thinking based on what you know. Obviously, the more you know, the better, clearly.
For sure.
The more you know, that helps you. But sometimes for ones that, if let's say we don't know too much about it, but you know something. So you can try and extrapolate and think in that minute, think what is the most likely answer based on what I do know. So it's just a way to think about test taking. So. Okay, number 7, this is very factual. This is one, again, where it's like, I don't know, but what do I know? So number 7, at what amount of blood alcohol level is a driver determined to be impaired in most states? There you go, Mohammed. I don't know if maybe you've had as much exposure, but you know, take a shot. I'll be honest. I don't think I know either, but I'll take a shot. So.
Maybe 0.1.
0.1, yeah. So, for me, I seem to I don't know for sure, but I want to say I feel like it's less than 0.1. Whenever I hear about it, I believe it's less than 0.1.
Okay.
So, and here's the other thing. The other thing is, I bet you, I'm thinking that this question may be saying that, you know what, we want to emphasize how low the threshold is, you know?
Mm-hmm.
It's not a high, no, it's a low threshold by which you're impaired, because I feel like not an agenda, but a point that the question is trying to make is that it doesn't take much, okay? It doesn't take much to be impaired. That's why we take it seriously.
Yeah.
So I'm going to guess A on this one.
Okay.
Okay, let's see. Number 7. It is B, Mohammed. It is B. Oh, man. I was close, huh?
Yeah.
So you picked C. I picked A. The answer was B. Oh, man. Okay. Well, let's take a look, shall we?
Sure.
So drivers are judged to be impaired at levels of 0.05% in most states. They are considered to be under the influence at 0.1%. Wow, good job. So they're under the influence of 0.1%. Okay, well, there we go then. Somebody who does not exhibit signs of intoxication at the levels of 100 milligrams per deciliter or higher is probably alcohol dependent, because alcohol tolerance is evident.
Yeah.
All states have adopted 0.08% as the legal limit for operating a motor vehicle for drivers 21 and older. Oh, so it's 0.08%, which is the limit. Okay. Drivers younger than 21 are not allowed to operate a motor vehicle with any level of alcohol in their blood. Okay. Sound good?
Yeah.
Yeah.
In Poland, they are extremely strict, by the way.
What's
Not
that?
even in Poland, they are extremely strict about the amount of alcohol they can tolerate. So I've noticed they take that into consideration, not even a small sip of alcohol if they are planning to drive.
Really? Wow.
Yeah.
Do they have a cutoff like in the US?
I'm not sure, but I heard the consequences are pretty rough, so they don't even risk it. Any amount, they just don't drive.
Wow.
If they are planning to drink.
Wow.
I mean,
Okay.
that's better for their own benefit. Yeah.
Yeah. Okay. Okay. So it looks like so impaired is 0.05, under the influence is 0.1, legal limit in the US is 0.08, and if someone exhibits signs of intoxication, or if someone does not exhibit signs of intoxication beyond 0.1, then that is suggestive of tolerance. So, okay, I think we covered that.
Yes.
Good. All right, next. Regarding risk factors for the condition diagnosed in question 1, which of the following statements most accurately reflects risk factor status and identification? What would you say?
Um, I would go with C,
C, okay.
environmental, genetic as well,
Okay.
occupation.
Okay. So I'll be honest, I accidentally looked at the answer. So,
Okay.
so we could just jump straight to that, I think.
Yeah.
The answer in this case is E, B, and C. So let's take a look. Now, your rationale, when we come to B, there is no single risk factor that accounts. An absolute risk in first-degree relatives and that accounts for increased relative and absolute risk in first-degree relatives of patients with this disorder. Okay. And then C, environment. Okay, let's see. So factors that determine an individual's susceptibility to substance use disorder are not well understood. Studies of populations at risk for development of substance abuse have identified many factors that foster the development and continuance of substance use. These include genetic, familial, environmental, occupational, socioeconomic, cultural, personality, life stressors, psychiatric comorbidities, biologic and social learning factors, and behavioral conditioning. The concordance rate for alcoholism between fathers and sons and among identical twin pairs is very high. This suggests a strong genetic determination for this disease. Accordingly, family members of alcoholics, especially first-degree relatives, need to be screened and counseled for alcohol dependence and abuse. So, okay. Any questions on that?
What do they mean by the choice D? There's a clear risk factor stratification for this disorder.
Oh, I guess, yeah, it's a good question. In my mind, I think that, well, I don't know if there's some examples to compare to. So risk factor stratification, like if there was, let's see, what's another condition that might apply to? I mean, I guess what it suggests to me is that, there might be, if risk factors suggest maybe degree of risk, whereas here you have a list of risk factors, and these are all factors that interplay in a complex way. So they interact in a complex way to increase risk, but we don't exactly know how they interact. We don't necessarily know the degree of complexity. We know that they are factors. How big of a factor they are, not quite clear. I guess, father, son, and twins, there's maybe a little bit stronger there. But beyond that, we really don't know how these risk factors interact. It appears to be complex to result in this elevated risk. Other risk stratification schemes may be more clear-cut. Perhaps an example is gynecological cancers. So the BRCA genes, for example, that would be pretty clear-cut. That's to say, oh yes, yeah, you are definitely in this category. That's more straightforward and more simple, less complex way to assess risk of an individual. So that's what it means to me, I think.
Okay. Yeah. Now it's clear why it's wrong. Yeah.
Yeah. Okay. Number 9. Which organ systems can be affected by alcohol abuse?
Oh.
Yeah, I mean, I would pick E. I would pick E. Cardiovascular, endocrine, heme. We touched on that a little bit, so I would pick
Yeah.
E. So, the answer indeed is E. That is indeed the answer. Let's see if we can learn something from this. Actually, I'm especially learning a little bit more about the pulmonary part. I mean, I think, a lot of times, not looking at the answer, I think a lot of times, folks with alcohol use disorder, they can be at risk of like aspiration pneumonia. They're at risk of they're at elevated risk of pneumonias, I think, in general. And so that's something that we oftentimes see in patients. And it's actually interesting because a lot of times these patients, they have multiple reasons for hyponatremia. Sometimes if they have a pulmonary infection, that can be a reason for like an SIADH type syndrome, because sometimes, these pulmonary lesions can cause that. The alcoholism itself is a reason for the hyponatremia. And then there was another reason I was thinking of. Anyway, yeah. Anyway, that's something that sometimes you see. So,
Even for sorry.
Yeah.
For newborns as well, related to your work with women health and pregnancy.
Yeah.
Alcohol can cause in the newborn.
Yeah. So fetal alcohol syndrome. Yeah, and that's actually, I think, a question coming later. The thing about that with women with pregnancy is that there is no determined safe alcohol level.
Yeah, no.
That's sort of the main concept there. And absolutely, fetal alcohol syndrome is a risk, and it's dose dependent. So, a lot of times women who are pregnant, they might have a glass of wine here or there. And it's like, well, there's no safe limit, but, you just counsel basically.
Have you had this problem before?
Fine. I'm sorry?
Have you had this problem working with women who continue to drink or smoke?
Smoke for sure. I mean, and that depends on the population. So a lot of times women will think, well, I'm pretty much fine if I have a glass of wine here or there. And a lot of times, as far as outcomes, because it is dose dependent, it ends up being okay. But as a provider, we don't know what the safe limit is, so we would
exactly.
to avoid. So there's that. And then the other extreme, where women have a definite alcohol use disorder, absolutely, those are patients that you want to be more aggressive in terms of counseling and connecting with other professional counseling. And you need significant behavioral health intervention at that point in time. Once in a while, yes, it is something. So tobacco is something that is a much higher, so tobacco use disorder is a much higher prevalence than alcohol use disorder in the pregnant population. And I want to say in the general population as well. So, yeah, definitely see it. Yeah. It's an issue that comes up.
It can happen.
Yeah. Well, let's check out the answer for this. So complications of the cardiovascular system, I think we touched on that. Elevated blood pressure. It's interesting. I had thought that alcohol has a vasodilatory effect. And to be honest, I need to double check that. But I think the way that alcohol causes secondary hypertension is actually, I thought, like increased vascular resistance at the arteriolar level by perhaps vasoconstriction, I thought. So I might need to double check the action of alcohol directly on, vasculature, to be honest. But the elevated blood pressure, it's reversible. It's reversible with abstinence. Okay, so that's good to know. The alcoholic cardiomyopathy we talked about. Sinus tachycardia is actually is actually a feature, as well as certain arrhythmias. In fact, sometimes you have like the holiday AFib, like the Christmas time or Thanksgiving AFib, where, you know, they go out, they drink, and then they get AFib right after. So yeah. Okay, so endocrine complications in men. Oh yes, so this is important as far as like hypogonadism. So endocrine complications in men include low testosterone and, like you mentioned earlier, Mohammed, increased estrogen levels. Okay. And a decreased libido, testicular atrophy, and impotence. So those are some endocrine manifestations. Women experience menstrual irregularities and sexual dysfunction and are at increased risk of breast cancer. So that's important.
Oh yeah, this is I remember that question I got in an exam. I shouldn't mention. It was like alcohol related to one type of cancer, and in women especially, and it was, I remember, breast cancer.
Breast cancer, very good. I'm sure you got that question right, Mohammed.
Yeah.
So good. Excellent, good job. Okay, pulmonary complications include bacterial pneumonias and aspiration pneumonias. I think we talked about that. Especially when vomiting occurs in intoxicated patients. Okay, and then an increased rate of tuberculosis. Okay, so that's another sort of infectious association. Very often, pulmonary complications from smoking are present because 80 to 90% of alcoholics are cigarette smokers. Gastrointestinal complications include reflux, peptic ulcer disease, esophagitis, and of course, esophageal varices as a late complication. And then of course, alcoholic hepatitis, cirrhosis, and let's not forget pancreatitis.
Yeah.
Except for esophageal varices and cirrhosis, these conditions are often reversible with alcohol abstinence. Neurological complications include, like you mentioned earlier, Mohammed, peripheral neuropathy of the lower extremities. So that's interesting. There's emphasis there on the lower extremities. Wernicke-Korsakoff syndrome, hepatic encephalopathy, which definitely it occurs a lot in the inpatient setting as far as what needs to be treated, and alcohol dementia. Hematologic complications include iron deficiency anemia, macrocytosis, thrombocytopenia, neutrophil, lymphocyte, and thrombocyte dysfunction.
Yeah.
It was actually interesting is sometimes when patients are sort of in the vicinity of alcohol intoxication, when they become abstinent, the platelets actually rebound, and you have like a rebound thrombocytosis. Interesting.
Oh.
Yeah. So a lot of times when patients, during intoxication, platelets are low. And then when they're abstinent for a while, especially back in the day, it used to be when I was in med school, actually, patients were in the hospital longer, I remember. And we would round on patients every day. And of course, if they had intoxication, what happens is they're abstinent, and day by day, you would actually see their platelet count go up and up and up until eventually it's actually greater than 450, 500. So it was thrombocytopenia, and it became a thrombocytosis because of that rebound effect with their abstinence. So that was kind of interesting to see.
That causes some problems if they are on antiplatelet, for example.
Oh, well, if you have thrombocytopenia, a lot of times you will DC, like, let's say they're on heparin for DVT prophylaxis, DVT PE prophylaxis. You'll hold that. You'll make sure they're not on aspirin. You'll hold NSAIDs if they have that thrombocytopenia. But no, the thrombocytosis, it's usually, I've seen it as mild, and there's really nothing to do about that necessarily. But if they're in the hospital for a long time, then they definitely need DVT prophylaxis, as long as you don't have contraindications. So yeah. Okay, good. Great. Any questions there? No? Okay. Number 10. Which drug is or are useful in the treatment of alcohol withdrawal? What would you say?
Mm,
I know anticonvulsants are used. Clonidine, alpha block, no. Yeah. So E, since two of them seems reasonable.
So for me, I did not see the answer, but for me, I would probably pick all of the above. But here's my thinking. My thinking is that, sorry. There we go. So my thinking is that generally your drug of choice is benzodiazepines when you're treating alcohol withdrawal. So and in fact, there's something called the CEWA protocol that has been shown to give benzodiazepines as needed, as opposed to a scheduled basis, but you give it as needed, and the dose is dependent on a certain scoring scheme. We call it the CEWA score. And if you're beyond a certain score, you get a certain number of milligrams of benzodiazepines. The benzodiazepines can be short acting, it can be long acting. There's always an interesting debate on that, but personally, I've gone with short acting. Although if the CEWA scores are very high, in other words, you have severe withdrawal, then you may go to long acting benzodiazepines. Again, this is all inpatient now. We're not talking about outpatient management of withdrawal. So this CEWA protocol, where you give the benzodiazepines as needed based on their score as opposed to on a scheduled basis, that has been shown to decrease, I believe there are a few outcomes, less benzodiazepine administered, shorter hospital stay, I believe, and then lower incidence of withdrawal seizures. So that's that. Now, there are a number of adjunctive treatments that you can add. Clonidine and other antihypertensives such as carvedilol, which has alpha blockade as well as selective beta blockade, can be added. Oftentimes patients have hypertension, in fact, as you would expect. So sometimes these antihypertensive agents can be useful adjuncts in the treatment of withdrawal. So that's clonidine. Barbiturates, another adjuncts to consider, and anticonvulsants. Those likewise. Other adjuncts to consider include like hydroxyzine, which is can be used for the treatment of anxiety. That can be added on. So all of these can be added on when treating an inpatient. In the outpatient setting, at first, I was like, oh no, there's no benzodiazepines as an outpatient for alcohol withdrawal. And that's still by and large the case. But for maybe some select patients for which honestly, I would consult with a psychiatrist before doing it. For some select patients who the withdrawal is mild and they don't have a history of withdrawal seizures and they're reliable, potentially maybe you can consider outpatient management of withdrawal with benzodiazepines. But there are enough other agents that honestly, I would consider those first. And if I were to do benzos as an outpatient, again, I would probably consult with a psychiatrist beforehand, is what I would do.
Okay.
So, having said all that, who knows, Mohammed? Maybe I'm wrong. Maybe it's not E. Let's see. 10. Oh, it is indeed E. Let's see what they have to say. The mainstay of therapy is long-acting, so interesting, long-acting benzodiazepines such as diazepam, tongue twister, chlordiazepoxide, which is Librium, and clorazepate, given in decreasing doses. Okay, interesting. Maybe it's a little different experience that I have, but anyways. Okay. Oh, and I did mention, actually, there's a nice little debate, nice healthy debate between short acting and long acting, but anyways. Clonidine is sometimes used to reduce non-adrenergic symptoms. Antipsychotic agents such as Haldol are useful in addition to benzodiazepines in patients with hallucinations and agitation. Also, an adjunctive agent based on the presence of certain symptoms. Barbiturates and anticonvulsants, such as Depakote and Tegretol, sometimes are used as anticonvulsants. And actually, of course, you'll have some patients that are, well, I think anticonvulsants in this case, it's not really being referred to the way I articulated. It's sometimes you get withdrawal seizures. So anticonvulsants would be indicated. Although benzodiazepine would really be your first line in the event of a withdrawal seizure, actually. So my most common experience, I mean, I'll be honest, I've never had a withdrawal. I don't think, I might have to think harder, but I don't think I've had a withdrawal seizure when a patient is being detoxed. So my most common experience is using anticonvulsants as like an adjunctive. And actually it could be useful in a patient maybe with a history of a withdrawal seizure who does come in. So anyway.
Maybe it's useful also because it's used in general to abstain from alcohol. But it's not the first line for sure.
What's that, Mohammed?
The anticonvulsants, some of them are used for abstinence from alcohol.
Yeah, so topiramate is is probably your most common one. Absolutely. So this goes to medication-assisted treatment options for for alcohol use disorder. So number 11, how is alcohol withdrawal syndrome best defined? What would you say? Oh, did I see the answer? Shoot, I need to be careful not to see it. I think I saw it, but anyway. What would you say?
A seems right. Drug-specific withdrawal signs, reduction, cessation of drug use, a state in which the physiological interfere.
Yeah.
So maybe all?
Yeah, I admit I saw the answer, and I believe it is E. Yeah, it's E. I'll tell you a story. One time I had a patient, she was admitted for, I can't even remember. Yeah, I can't remember exactly what the admission was for. It had nothing to do with alcohol. But then, she became tachycardic, okay? She became tachycardic. I think she might have developed a fine tremor. She had an AST to ALT ratio of 2-to-1. And it's like, and you ask her about alcohol, she denies it every time. Every single time she denied alcohol use. And then my last day on the service, as the day was winding down and a new team was coming, we got, I don't know why, I can't remember how many days, this was maybe a couple of days into her hospitalization, and it was last day of that I was on the service. We got a blood alcohol level, because it's like she denies it, but everything is pointing to alcohol. And then it came back, let's see, it wasn't too long into her hospitalization, but it came back that if I recall this correctly, there was alcohol in her system. And it's like, okay, listen, new team is coming on. I'm checking out to the new team. You guys talk to her about it. I'm off the service. So she lied, it was like a bald-faced lie each time. And so she was in denial. Oftentimes patients, and this is actually, I believe this is even a board question, when patients are hospitalized, they will develop symptoms of withdrawal and just not be forthcoming about their alcohol consumption prior to their hospitalization. And then, of course, in the hospital, they're not drinking. So then withdrawal happens. So it's just something to be aware of. And so anyway, when we look at this, it's, yeah, signs and symptoms, you know, and this patient, I remember she was it started with her tachycardia, as best as I can recall. I was like, why is she tachycardic? And I really need to remember why she was admitted, actually. That's relevant. But it was a long time ago. It was probably over 10 years ago. I just can't recall. But I remember saying, do we drink anything that contains alcohol? And the answer was no, no, no. And yeah. So if we look at A, following reduction or cessation of drug use, in this case, it's alcohol. And it's a syndrome. You know, it's a constellation of signs and symptoms. So there was that. Physiologic or behavioral effects of a constant dose of a psychoactive substance decrease over time. So that's tolerance. And then C, pathologic state that follows cessation or reduction in the amount of the drug used. I'm trying to think, how is that different than A?
Yeah, well, that's what I was thinking when I was reading the options.
Yeah.
By the way, I used to live, he's my friend now, and he's doing great now as a medical student.
Yeah.
He had alcohol use disorder at that time when I used to live with him.
Yeah.
And he kept on trying to stop, and he a couple of times had these withdrawal symptoms.
Yeah.
Although he never had seizures, but yeah, and then he sought help, and now he's doing fine. So when I read such questions, I can see them in my head.
Absolutely, absolutely. Yeah, there are stories behind these concepts. Absolutely. So, okay. Well, yeah, let's just move on to the next one. I think that one's pretty straightforward. So considering the patient described, which of the following diagnostic imaging procedures is definitely indicated? So thinking about that patient. So think about that, Mohammed. I'm going to step away for like 2-3 minutes. I'll be right back. Okay. All right, Mohammed, what'd you pick?
I picked B.
B. Yeah, I would agree as well. Just because obviously we were worried about heart failure. Yeah.
CT of the head, I'm not sure what's the indication for that. And
Right.
ultrasound maybe later.
Yeah. They all can be considered. Certainly, they're not unreasonable things to consider. But I think probably the strongest need is for B. Let's see our answer. Well, the answer is E, actually. Yeah, so let's look at the rationale, shall we? So the imaging studies indicated in this patient include, they just include it all. They're just telling us. So it's a chest x-ray, CT of the head, abdominal ultrasound, and echocardiogram. An echocardiogram should be obtained to define the thickness of the left ventricular wall to determine whether or not left ventricular hypertrophy is present, and also because obviously we suspected cardiomegaly on exam with the displaced PMI. So that's okay, that we understand. In addition, an electrocardiogram will aid in the diagnosis of LVH and determine, among other things, the absence or presence of cardiac arrhythmias. Sure. A chest radiograph is justified on the basis of probable cardiac enlargement, that is, to measure the cardiac thoracic ratio. And Mohammed, the cardiac to thoracic ratio, if it's greater than what, indicates cardiomegaly?
Sorry, I'm not sure.
It is roughly, if the cardiac to thoracic ratio is greater than half, if it's greater than 0.5. So basically, you just check the diameter of the cardiac silhouette, and then you assess if that you almost use your thumb and your index, or your thumb and your pinky finger. You almost use them as like a caliper, and you just assess if it's greater than the diameter of the whole thorax, greater than half the diameter of the whole thorax. So you kind of use your fingers as like a caliper for the cardiac silhouette, and then you use it to say, okay, is this distance, is it greater than half the thoracic diameter on the chest x-ray? A lot of times you look at it, you're like, oh, well, clearly this is more than half, you know? But anyway, that's kind of what it's talking about. So, right. So a CT scan will rule out causes of cognitive disturbances that may be related to alcohol use. Okay. Including intracranial bleeding. It may also detect causes of cognitive disturbances unrelated to alcohol. An abdominal ultrasound will help determine the cause of liver enlargement and help determine the spleen size. So, what do you think of that answer?
Interesting.
Yeah. I mean, you know, I think, I agree. I think these are all things that we would normally get. Yeah. I mean, I think that makes sense to me. The chest radiograph, if you get an echo, you should probably get a chest x-ray, I suppose, to be honest.
Isn't that enough, the echo, to see if there's any dilated cardiomyopathy or check for heart failure?
Yeah, it is, but there are other manifestations that go on in the chest as well. So the heart and the lungs are a system. So yes, we're looking at the heart, but also we cannot extricate the heart from the health of the lungs, and so the chest x-ray can definitely provide additional information, like if there's hyperinflation, for example. And while you don't necessarily diagnose COPD strictly from a chest x-ray, certainly it can give you additional information. And additional information that might give you, help explain some of the pathologies that you do see in the heart. So CT scan of the head, talked about that. Abdominal ultrasound at some point, yes. I mean, if you are worried about cirrhosis, you do need imaging of the liver. I mean, you just do. So other things that would sometimes happen is that, let's say a patient tested positive for Hep C. If they tested positive for Hep C and they have alcohol use disorder, then they're at greater risk of hepatocellular carcinoma of the liver. Yeah. So a lot of times we would get an AFP as well as a tumor marker to assess for that. And certainly if you're worried, so then obviously you would definitely get imaging in that case. I mean, that would go without saying. So that's just some extra
Regular
stuff.
imaging.
I mean, we get an abdominal ultrasound for sure. So like, let's say they have a history of Hep C, then you would get an AFP as a tumor marker, and clearly you would get an ultrasound with that as well, you know, to assess the echogenicity and assess for lesions and size and so forth. Assess for signs of portal hypertension as well.
Yeah.
You can get that data from an abdominal ultrasound. So, okay. Well, next up, number 13. Which of the following is the most, actually it's very interesting. When we looked at this question, we're like, oh, echo. Like we just jumped straight to it. And maybe it's just a lesson for us to just read and consider a little more carefully. Lesson for me anyway. Number 13, which of the following is the most likely explanation for the tremors observed on physical examination? What would you say?
D.
Let's see, D. Let's see, what would I pick? DT? No, that's kind of like an emergency. Alcohol withdrawal syndrome? Yeah, put a pin in that. Thiamine deficiency? No. Thiamine deficiency, in my mind, would be
Related to Korsakoff psychosis.
Right. It's related to Wernicke's and then Korsakoff. And then this is tremors is not psychosis. Alcoholic encephalopathy, that I would agree with that one more, I think. Yeah. I think alcohol withdrawal syndrome, you know, it's more some of the autonomic manifestations. So we'll see what the answer is. But I believe
they're asking about our patients, right?
Our patient, yeah. For this
Okay.
particular patient, yeah.
Okay.
Yeah, and you're right. You're right. Is he withdrawing? Not really. Not really. So you bring up a great point, Mohammed, is we need to think in context of the patient that was presented. So yeah, I would go with D as well. You picked D, right?
Yeah.
Oh, good. We're in it together. Let's see what the answer is. 13, D. That is indeed the answer. So the movement disorder that is demonstrated on physical examination suggests the early stages of liver failure and alcoholic or Wernicke's encephalopathy. Well, this is Wernicke's. Yeah. That's right. That's right.
Yeah.
We are talking about Wernicke's here. Yeah, okay. It may develop into asterixis, which is the arrhythmic flapping tremor of the fully extended hand, and sometimes referred to as a liver flap. So that's your answer. So this is so alcoholic encephalopathy. Yeah, for some reason it didn't occur to me that this is Wernicke's encephalopathy. Yeah.
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 It's really common, and they always ask about the treatment for it.
Right.
Which is lactulose.
Exactly. Yeah. The lactulose is definitely a drug of choice. And the way that you know that the lactulose is working is how many bowel movements the patient is having. If the patient is having frequent bowel movements, like 4, 5, 6 bowel movements in a day, then you know that the lactulose is effective. Yeah. And one way to monitor the encephalopathy actually is getting ammonia levels.
Yeah.
Get ammonia levels and it's elevated, then you know that's
check again.
Yeah, you give the lactulose, you ensure that the patient is having adequate number of bowel movements, and then you follow the ammonia levels, and you should notice it go down, and you should notice the signs of the encephalopathy improve. So, yeah. And then, of course, if you do suspect Wernicke's, the other sort of thing to consider is just make sure that the patient is not inadvertently getting dextrose-containing IV fluids before the thiamine was replaced.
Yes, of course. Yeah.
So, I remember one time, so in residency, one time, this is embarrassing. We're talking about Wernicke's, and here I am, I'm sharing a story, but I should have recognized it right away. But there was a patient who was actually developing Wernicke's. And I remember I was sitting with my attending, and we were talking about, because his symptoms, I think, again, long time ago, see if I can recall, I think he had nystagmus actually, but he cognitively was definitely declining, and he was a known alcoholic, and we were trying to consider the differential for the patient. And I told my attending, I was like, doesn't this look like Wernicke's? So he is getting dextrose. Maybe we should stop it, just make sure he gets all the thiamine in. And yeah, so my attending, I think at the time, he didn't think I was like
competent enough.
No, like, I think at that point, no, but I think I was very green. I was very green. I was very inexperienced,
Okay.
and so I know, like, and he knew me from the start of my residency. So he's like, this guy, I hope this guy eventually makes it, But then after this, Mohammed, I was good.
Yeah, you got his respect.
After this, because then that's what we did. We went ahead, we stopped the IV fluids, ensured that he got an adequate thiamine infusion. But nowadays, what you do is we give something called the quote-unquote the banana bag. The banana bag.
Yeah, I was going to say. Yeah, they come together.
Exactly. And I want to say, at that time, I don't think we had a standard banana bag, to be honest. I think I remember ordering them separately. Like, I remember ordering the IV folate, IV thiamine. Like, I remember ordering them separately, actually. But of course now it tends to be a yellow color because it's the thiamine folate, and also there's a multivitamin in the bag as well. Okay. So it looks yellow. It's a yellow bag. That's why we call it the banana bag.
Banana bag. Okay.
But it sounds like you use that as well in Lebanon.
Yeah.
Yeah. Okay. Awesome. Good. So yeah. So it's interesting because now we know we use the banana bag, so we don't forget. We don't forget to order it, obviously. So. Okay. Good. I think that's it. Did we cover everything here? Yeah, I think we did. Okay. Moving on. A 26-year-old man comes to your office. I guess this is another case. Comes to your office for a periodic health examination before he gets married. When you question his alcohol intake, he replies that he is a social drinker. Once that is established, what should you do? What would you say?
I would ask about an estimate of the number of drinks per week, because social drinking is too vague, and I would even ask what type of drinks. For example, in Poland, they don't consider beer as or wine. Some of them, they don't consider it alcohol. Do you drink alcohol? They say no. Do you drink wine? Oh yeah, wine. Yeah, only when I'm eating. So they consider it as if as a beverage, more of.
Wow. Okay. Thank you.
You should always make sure.
Yeah. Got it. Okay. Sounds good to me. The answer is definitely E. And so Boy, we have a lot of information with this one. Let's see if we can just run through it. Basically, yeah, social drinking has little meaning. We talked about that. We want to be more precise. Got it. So the first step is to determine whether or not a patient drinks. The second step is to determine how much alcohol a patient drinks. It helps to have the patient estimate the number of drinks per week because many drinkers have irregular patterns with heavier weekend use. Because alcoholism is a disease that is usually minimized, it is only when the need to drink starts to seriously interfere with social or occupational functioning, or the patient is apprehended while driving under the influence of alcohol, that the alcohol abuser will become aware of having a problem. If the family physician can express concern about the effect of the quantity of alcohol consumed on the patient's health before something dire happens, treatment can be initiated at an earlier time and serious sequelae of the disease can be prevented. A useful instrument, they actually talk about the CAGE questionnaire in this one, so this is a little bit outdated. So we already know about that. They talk about another reliable screening tool, which is the Michigan Alcohol Screening Test, or the MAST. This is a 25-item scale. It identifies abnormal drinking through its social and behavioral consequences with a sensitivity of 90%, with a sensitivity of 90 to 98%. A brief MAST shortened to a 10-item test has been shown to be similarly effective. These tests are less likely to be used in a primary care environment. The longer the screening, the less likely it is to be used, I think is fair to say. And I mentioned in my organization, we have just that one question that you pulled up, Mohammed. And then if that's positive, then we go to the other ones. We go to the audit, actually. Actually, the audit C, I believe. Yeah, that's the one that we jump to. So, and I will say it's because we're a community health center, I think that we do that, because behavioral health is an important part of what we do.
Yeah.
Okay, good. So next case here. A patient with short-term memory deficits. A patient who you suspect of alcohol use disorder demonstrates significant short-term memory deficits. He then tries to cover up those deficits by making up answers to questions. So, number 15. Go ahead.
Yeah, I was gonna say the answer. What can this is remind me of Koreshkov psychosis.
Yeah. So let's go ahead and so it looks like B is your answer.
Yeah.
Wernicke's encephalopathy, I would agree, that does not appear, Wernicke's encephalopathy is more acute. The Korsakoff psychosis is more chronic, so that makes more sense. Alcohol-induced psychotic disorder, alcohol-induced psychotic disorder with delusions or hallucinations. No, not really. There's no evidence of delusions or hallucinations here. That was not cited. Alcohol-induced persisting dementia. I'll be honest, I don't know what that is. So, well, I mean, I think, I think there was an earlier question. Hold on a second. Alcoholic dementia was here. So, if I may, let me run back to that. Let me run back to that.
We differentiated it.
Oh, yeah. Yeah. Okay, got it. Okay. So let's move on to that question. Okay. So, all right. So the answer is B, right? Let's take a look. The answer is indeed B. So the patient has alcohol-induced persisting amnestic disorder called Korsakoff psychosis. Okay. So if we go back to that number 6, if we go back, this is your Korsakoff.
Korsakoff, yeah.
That's your Korsakoff. Okay. That's your Korsakoff. Very good. And then if we go back to here, Alcoholic encephalopathy. That was your Wernicke's. Okay. So, good. Okay. So, let's continue on. So this patient has alcohol-induced persisting amnestic disorder called Korsakoff psychosis. Patients with alcohol-induced amnestic disorder have the most difficulty with short-term remembering recent events, although deficits in long-term memory may be noted as well. Okay. And then here's that dementia that's more of the cognitive, more global cognitive
functioning in his life, yeah.
Very good, absolutely. Okay, so good. All right, so it looks like we're able to make that distinction. All right, so the answer here is B. Okay, 16. The feature described as making up answers to questions is known as?
Confabulation.
Yep, I would agree. Number 6, confabulation. That's that. Okay, so pretty straightforward. Basically, yeah, you make up answers to questions that require you to use your memory. Yep. Number 17. What is the cause of the disorder described in this case?
B.
Yeah, I would agree. 17, pretty straightforward. It is B. Let's see if there's anything new here. So this disorder, the cause of this disorder is chronic deficiency of the vitamin thiamine. Whenever a patient is in a confused state, that may be related to alcohol abuse, intravenous thiamine should be administered. Okay? Perfect. That's what we were talking about. Pretty straightforward. Number 18. This is interesting. The word alcoholism means different things to different people. Of the following, which is the best definition of alcohol? What would you say?
D.
Yeah, alcohol abuse. I like D too.
Because I remember in my GI rotation, our doctor faced a lot of people having liver problems because of alcohol, and she stressed that alcoholism doesn't only cover abuse, it also people who have dependency on it.
Right.
So this or, yeah.
Right. I think for me, I'm having a hard time distinguishing D from C, and I'm having a hard time distinguishing D from A.
A means like both of them. They
right.
should be present to say this is alcoholism.
Right. But D says and/or, because yeah, that's the thing that I'm struggling with. I think if I have limited time, because I'm having some difficulty distinguishing between these three, I might go with E.
Okay.
E for sure is not it. I would agree, for sure. To your point, Mohammed, the story of your story there. But let's see what the answer says. It is E.
Okay. Good job.
Thanks, Mohammed. It's good practice for me too for my next board exam. So.
Yeah.
So E. Let's see what is a more ideal definition of alcoholism. So it is defined as repetitive but inconsistent and sometimes unpredictable loss of control of drinking that produces symptoms of serious dysfunction or disability. Okay. It's very interesting because with AA, Alcoholics Anonymous, the first step, I don't even know if we can bring it up and share the screen, but the first step of there's like a 12-step program. the first step is to admit, like I would admit I have a problem. Let's say I have alcohol use disorder. I admit I have a problem. But part of admitting that I have a problem is to say that I admit I have a problem, and but I don't have alcohol use disorder. I just want to make that clear. So if we're going to put this on here, but I just want to make that clear. I do not. But this applies to many different conditions. Really, the thing is that the first step is to admit I have a problem. Part of admitting I have a problem is that I have lost control. That is sort of part of it. So it makes this sort of resonates with that 12-step program. And you know what we could do real quick is we could go to Wikipedia. Oh, is this your cat's first appearance, Mohammed?
Yeah, my small kitten.
Cute. Is it he or she?
She was having a nap behind the laptop, but now she decided to
Oh, no. She's awake now.
Yeah.
So even if you just go to Wikipedia, and you go to the 12-step program. So let me do new share. It's a reasonable one. Okay, so here it is. So the 12 steps. First step is we admit that we are powerless over alcohol, that our lives have become unmanageable. Like, my understanding as part of this concept is that we don't have really control over this. This has control over us. We don't have control over it. So, and to admit that. So it makes sense then. It makes sense then that, you know, that would be part of the definition of alcoholism. So, okay. Oh, by the way, what's your cat's name?
We call her Oreo.
Oreo, that's cute. She must have like the colors, I'm guessing, the Oreo colors.
Yeah.
Oh, cool, very nice. All right, we're getting towards the end. Which of the following statements is or are true about the dietary guidelines for Americans' recommendation for the use of alcohol? What would you say?
A is wrong.
Okay.
Up to 1 drink per day. B for sure wrong. Up to 3 drinks per day. Drinks. D.
Sorry, I'm just sending a quick email. So let's see. Up to 2 drinks per day in men and women younger than 65. Well, I would say there is a distinction between men and women as far as alcohol, capacity.
Yes. Yeah.
Some of those, enzyme variances we talked about. Up to 1 drink per day for women who are pregnant. Oh no, so we talked about that. There is no safe limit in pregnancy. C.
So definitely no recommendation for 1 drink.
What was that?
Because the question is about guideline for Americans recommendation. No physician will recommend up to 1 drink per day.
Exactly. It's it suggests that there's a safe limit, which there is not. C, up to 3 drinks per week for adolescents younger than 21, but they should never drink and drive. Well, frankly, it's not a recommendation I've ever come across. D, persons recovering from alcohol use disorder should not drink. That is true. I think, now I don't know what the answer is, but when in my, one of the rotations I did in residency is I spent a week in an inpatient rehab center for alcohol. And I spent a lot of time with the residents. They were in this program that for them lasted a month long, and it was a very intense program of psychological interventions, of counseling, group therapy. I loved it, actually. I loved spending time there. Yeah, it was real, and I loved connecting with some of the residents and the patients. You know, it was very good to see. Now, the impression I took away from that, so when in their path to recovery, they described it as you're on a road, and it's very easy to fall off the road because the distance from the road to the ditch is always the same. No matter how far along you are on the road to recovery, the ditch is right there. It's very easy to fall into the ditch. And part of that was just staying away from alcohol and remaining abstinent. So that was the concept. That was a concept that I took away from my educational rotation there. That's why D sort of resonates with me about, well, you know, you really need complete abstinence. But let's see if maybe there's some other concepts to learn here. So what's this E say? E says up to 1 drink per day for persons who plan to engage in activities that require alertness and skills such as driving a car. Yeah, I don't know about that. Yeah, I mean, we have, we just reviewed the alcohol limits, right? Which was, what did we say? We said there's a legal limit of 0.08%, there's impaired, which is 5%, and then intoxicated 0.1%. So I don't know about 1 drink per day. So I will tell you what the recommendations that I've been sharing with patients is that generally for men, again, we need to look at the answer, but for men, I've been saying 14, like less than 14 drinks per week, and for women, less than 1 drink per week, per day. Let me say that again. Let me say that again. For men, less than 14 drinks per week, and for women, less than 7 drinks per week.
Okay.
And to your point, Mohammed, yes, you need to determine what kind of drink as well, for sure. So generally, like a beer. So that's what those are some safe limits that we've been recommending for patients as far as general guidelines. So having said all that, let's see what the answer is. The answer here is D. All right. I'm glad my rotation paid off, huh?
Yeah, for sure.
So D, let's see what they say. So a standard drink is defined as 13.7 grams or 0.6 ounces of pure alcohol. This amount of pure alcohol is in a 12-ounce bottle of beer, a 5-ounce glass of wine, or a 1.5-ounce shot of liquor. I guess that makes sense. So you have your beer, your 5-ounce glass of wine, and then 1.5 ounce, I guess it's like this big, shot of liquor. Okay, so that's it. So it's a shot of liquor, a glass of wine, or bottle of beer. Okay. The dietary guidelines for Americans' recommendation for alcohol are as follows. Up to 2 drinks per day for men younger than 65 years. Up to 1 drink for women, 1 drink per day for women under the age of 65. Okay. So what I've been recommending is a little variation on that. I've been saying less than 2 drinks per day. You know what I mean? Like here it says up to 2 drinks per day. Yeah. So So that's one thing. The other thing is the age of 65, So I get the vast majority of my patients are under 65, so I guess that's why. But now women who are pregnant or trying to become pregnant should not drink, right? So that's So when it comes to prenatal preconception counseling, so sometimes women come in and say, I want to get pregnant, let's take care of chronic conditions and other things so that I can be well prepared to get pregnant, they should be advised not to drink. Adolescents younger than 21 should not drink. Okay, so under 21 should not drink. Persons recovering from alcohol dependence should not drink. Okay, so that's consistent with what we've been talking about. And then persons who plan to engage in activities that require alertness and skill, such as driving a car, should not drink. It's interesting. It's like there's no safe limit if you are pregnant, and there's no safe limit if you're going to drive, is kind of what I take away. What do you take away from it?
Yeah, exactly the same. Driving, you should never drink.
Yeah. So
especially because you cannot regularly check your own blood alcohol. So you can say, oh, it's still not much, one drink, and then you drink another one. So
right, exactly. Yeah. So good. Next, what is the percentage of the U.S. population who will suffer from an alcohol use disorder during the course of a lifetime? So I believe this is talking about lifetime prevalence.
I think C, 14%.
Yeah, so I don't know the answer to this. Yeah.
I think I read it somewhere some time ago.
Okay, then I'll go with what you say. No, so so half of people, that feels like a lot. That feels like a lot. 1 out of 7 feels about right. Yeah, let's go with, I'll go with C2. And you're right, Mohammed, the answer is C. So in 1994, well, boy, this is a long answer. I think we're good. I think we're good. 14%.
Yeah, this
got
is
it.
just epidemiology.
Yeah, let me see. And let me just briefly, in 1994, there was a survey that found 23% of the population reported alcohol use or dependence. Recent studies suggest that almost 14% will have something in their lifetime. Almost 8% meet criteria for alcohol use disorder at any given time. Interesting. So that's like 4 out of 50, 1 out of like 2 out of 25 people. 2 out of 25 people will meet criteria for alcohol use disorder at one particular time. So that's like the prevalence. That's the actual prevalence. And then lifetime prevalence is 14%. So men are 2 to 3 times more likely than women to be problem drinkers. Just skipping ahead here. When women drink even moderately in pregnancy, damage to unborn children can occur. It's not necessarily birth defects and fetal alcohol syndrome, but sometimes learning problems. So let's leave it at that. So good. So some things with epidemiology here. Next up, let me see. Which of the following behavioral interventions is or are most effective in the long-term management of alcohol use disorder?
D, CBT and motivational for any use disorders is good.
Yeah, I guess I think it's good. I think for me, I'm a little skeptical. And again, I admit I do not know the answer.
But social. But you mentioned before about the group therapy, which is extremely important too. So does that fall under network therapy maybe?
I think it does. I'm skeptical that any one is better than another, and for that reason, I'm inclined to pick E.
Okay.
But I don't know the true answer, so yeah, I mean, I think they're all of value. So let's see. 21 is indeed E. All right.
E. Okay. You are ready, doctor, for your board.
Yeah. Thanks, Mohammed. Thank you. So E, a large number of behavioral approaches have been tried, including the popular Alcoholics Anonymous 12-step program. Oh, that's another thing. Hang on one sec. I'm going to step away for just a moment. Hey, Dr. Cohen.
Sure.
Oh yeah, I am delayed coming over. Can I call you back in like 5 minutes, Dr. Cohen? Yeah, I'll be there in about 30 minutes. All right, thanks so much. Yeah, bye-bye. All right, sorry about that. So yeah, so like even the 12 steps program, Alcoholics Anonymous, even that there's an argument really, or maybe it's not even that much of an argument, but there isn't like robust data as far as saying yes, this is definitively validated sort of treatment. I think there's a lot of value in it. But like relapses are very high, so there's questions about long-term outcomes. But that's the 12-step AA program, right? So, and it mentions it here. So, so it mentions it, and then it says, however, in studies comparing the different psychosocial interventions, including cognitive behavioral therapy, social behavior and network therapy, and motivational enhancement therapy, no one method appears to be superior to another. The physician must individualize choice of therapy on the basis of long-term knowledge of the patient. Studies indicate that a combination of behavioral therapy and pharmacotherapy may be best to treat long-term alcohol dependence. All right, and that brings us to 22, which is our last one, I believe. Which of the following pharmacotherapeutic psychosocial approaches works best in the long-term treatment of alcohol use disorder?
Motivation. I will go with C or C or A. I'm confused.
Yeah, so again, I don't know what the answer is, but for me, I am more inclined to pick A because that is a drug of choice. Now, topiramate can be used as monotherapy or it can be used as an adjunct. Acamprosate is an option for patients with significant liver disease. Actually, that's really when you use acamprosate. It's when a patient has bad liver disease and you can't use naltrexone. So if a patient has cirrhosis, disulfiram is, in some there's some patients where they're a better fit for this therapy. So I think, but as far as like a general first line, I think naltrexone would be that. So for that reason, I'm inclined to go with A.
Okay.
But let's see what the actual answer is. So 22, it is indeed A. So 3 medications, disulfiram, naltrexone, and acamprosate, are currently approved by the U.S. Food and Drug Administration for the treatment of alcohol dependence. Naltrexone is an opioid receptor antagonist. By the way, naltrexone it's also used in opioid use disorder as well.
Yes.
And that's another reason why naltrexone can be helpful, because remember that correlation with opioid use as well. So naltrexone is an opioid receptor antagonist whose efficacy in conjunction with cognitive behavioral therapy in the treatment of alcohol dependence has been demonstrated by several clinical trials. It is available as oral and injectable. That's right. So naltrexone can be given once a month, and the brand name is Vivitrol in the United States. So naltrexone can be taken as a pill every day, or it can be given as a monthly injection. It is available in oral and injectable modes, has few side effects other than nausea. Nausea is pronounced, by the way, with naltrexone. So that's something to keep in mind. And headache, also important to keep in mind. And has virtually...
Constipation as well.
What's that?
Constipation or no?
Constipation I haven't come across... maybe. I wouldn't doubt it. And it has virtually no abuse potential. However, it must be used with caution in individuals with liver disease and not at all in patients with liver failure, acute hepatitis, or narcotic use. Oh, that's the other thing. So it's for opioid use disorder, but you cannot be currently on an opioid and take naltrexone. And that's why patients with naltrexone, they need to wear a band and have a wallet in their card saying that they are on this medicine. So for example, if they're admitted to the hospital, healthcare workers can see that they're on this medicine so that they know not to give the patient opioids, because So that's why it's important that they have that kind of identification. So yes, you have to be off opioids when you start naltrexone. The oral version must be taken daily. The injectable version works for 1 month, thereby increasing patient compliance. Acamprosate is thought to stabilize the chemical balance in the brain that would otherwise be disrupted by alcoholism, possibly by blocking it's like a GABA receptor, tongue twister.
Yeah, GABA.
Glutamatergic N-methyl D-aspartate receptors, while the GABA aminobutyric acid type A, so the GABA type A receptors are activated. A systematic review concluded that acamprosate is best for achieving abstinence, interesting, is best for achieving abstinence, while naltrexone is better in conjunction with cognitive behavioral therapy for long-term drinking control. Combining naltrexone and acamprosate has shown no additional benefit. Alcohol is metabolized in the liver by the enzyme alcohol dehydrogenase to acetaldehyde. So remember that pathway. So alcohol dehydrogenase metabolizes alcohol to acetaldehyde, which is further broken down to acetic acid by the enzyme acetaldehyde dehydrogenase. Disulfiram blocks the last enzyme, which is the acetaldehyde dehydrogenase, causing the buildup of acetaldehyde, which on ingestion of alcohol results in severe hangover-like symptoms. And that's the real overall result, not just the flushing that we talked about. It must be taken daily and is not used. We're talking about disulfiram, I believe. It must be taken daily and is not used in many primary care settings because of multiple side effects and contraindications. It is contraindicated in patients who are taking metronidazole, you got that one right, or have psychosis or cardiovascular disease. It is not recommended for patients with severe pulmonary disease, peripheral neuropathy, seizures, cirrhosis, or portal hypertension, chronic renal failure, or diabetes, or for those older than age 60. A rare but potentially adverse effect is hepatotoxicity. With the exception of off-label use of topiramate or fluoxetine, there are currently no new effective medications for alcohol dependence. These medications have been used with some success. Ongoing studies are in progress to determine the correct combinations of psychotherapy. That's pretty much it.
Interesting.
Yeah. All right, Mohammed. Well, I want to say I really enjoyed our time together. I really,
me too.
I'm going to miss this. So, if you need a letter of recommendation, I would look forward to providing that for you based on your participation and contributions and interactions to this. I really enjoyed it, Mohammed. So if ever you need a rotation, if a rotation like this would be beneficial for you in the future, would be happy to help with that. So
thank you so much.
Thank you, Mohammed. Otherwise, anything else?
Muharram couldn't make it today?
Oh, yeah, he couldn't. He actually emailed last night, and he said that he wouldn't be able to make it today. So I suggested that he just watch this on YouTube.
Sure.
Yeah.
Sure. Okay. And I emailed you for the letter of recommendation, but maybe on the other email. So maybe better to email you on your personal email?
No, I'll do it. I think, now that you mentioned it, I think I received it. I couldn't remember if it was yourself or Horam, actually. But
okay.
yeah, but no, I'll be happy to address that. You have my
Thank
email,
you so
so just stay in touch with me, and yeah, I'll be happy to help you with that.
Thank you so much, doctor.
Thank you, Mohammed. Okay, well, best of luck, and I hope to see you here in residency in the United States sometime.
To you too. Yeah, you never know. Maybe we will meet up one day. I hope.
You never know. You never know. Absolutely.
Good luck with your life and your boards.
You too, Mohammed. You too. Thank you so much, and stay safe.
You too. Bye.
Thank you. Bye-bye.